Dr.
start.
Smita, please start. At 5 minutes, you will get a short bell, and at 6 minutes, it will be a long.
Yes, ma'am.
Your time starts now.
Start.
Good morning, everyone. I'm going to present a case. A 9-year-old boy from Garhwa, Jharkhand presented to the IOPD with chief complaints of diminution of vision in left eye since 3 weeks, whitish opacity in left eye since 2 weeks. History of presenting illness. My patient presented with diminution of vision in left eye since 3 weeks, which was gradual in onset, painless, and progressive in nature. My patient had history of blunt trauma to left eye by stone while playing with his brother 1 month back, after which his parents noticed redness in his left eye for which they did not seek any medical attention. 2 weeks later, they noticed whitish opacity in the left eye for which they visited RIMS OPD. Past ocular history, there was no history of any infection or ocular surgery. Past medical history, there was no history of systemic illness. Family history is not relevant, and my patient belonged to a lower socioeconomic background. General examination. My patient was alert, conscious, and well oriented to time, place, and person. He is of average build. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and edema were absent. His systemic examination was within normal limit. Ocular examination, lid and adnexa, globe position and size, both eye within normal limit. Lid and adnexa, both eye within normal limit. Both the eyes were centrally fixating. Extraocular muscles movement was free and full in all gaze. Right eye, the uncorrected visual acuity using Snellen's chart was 6.6, whereas in the left eye, the uncorrected and best corrected visual acuity was finger counting close to face. IOP was normal for both the eyes. Conjunctiva was normal for both the eyes. Cornea was clear for both the eyes. In right eye, the anterior chamber had normal depth and was quiet, whereas in the left eye, it was shallow. The pupil in right eye was 3 millimeter in size, round and reactive to light, whereas in the reactive to light, traumatic mydriasis. In right eye, the iris was within normal limit. The right eye lens was within normal limit, whereas the left eye had intermittent cataract. The fundus of the right eye was within normal limit, whereas in the left eye it could not be assessed due to hazy media. So my differential diagnoses are traumatic cataract, developmental cataract, and uveitic cataract. My provisional diagnosis is left eye traumatic cataract with traumatic mydriasis. So investigations that was given were B scan. Vitreous cavity was anechoic and retina was on. RBS was 105 mg per dl. Serology was non-reactive. Serum electrolyte, CBC, LFT, RFT, PT-INR, chest X-ray, and ECG were within normal limits. Biometry was done using A scan. Management. My patient was admitted in eye ward for left eye phaco aspiration and PCIOL implantation. The pre-op advice was BP and consent were taken. Eye drop fluorbiprofen 0.03%, 1 drop 3 times was given. Eye drop tropicamide 0.8% plus phenylephrine 5%. 1 drop 3 times was given. A patient was kept NPO, 6 hours for liquid and 12 hours for solid, and IV fluid RL 1 unit was advised. Under general anesthesia, left eye phaco aspiration and PCIOL implantation was done. PNP was done after installation of antibiotic and steroid eye drops. Post-op advice, patient was kept NPO for 6 hours. IV fluid RL was advised. Injection ceftriaxone 1 gram IV, half ampule BD was given. Injection pantoprazole IV, half ampule OD was given. Injection diclofenac IM, half ampule SOS was given. Tablet prednisolone 20 mg once day was advised.
Dr. Advita, we have lost you. Are you there? Dr. Advita? Okay, so because we have lost Dr. Anvita, we can go to the next presentation. Dr. Pragya Chauhan.
Dr. Pragya, are you there? You're ready with your
Yes, sir.
presentation? Please start.
Please share your screen. So at 5 minutes, we'll give a short bell.
Your time starts now.
Good afternoon, everyone. This is Dr. Pragya Chauhan, first year resident, is going to present a case of a 22-year-old unmarried male who presented to our OPD with diminution of vision, right eye more than left eye. The DOV was gradual, painless, and progressive in nature, associated with nyctalopia. There was no history of pain, redness, photophobia, floaters, and flashes of light. There was no history of any other ocular trauma, or also there is no history of any JHOS. Past history and family history was not significant. On general examination, patient was alert, conscious, and cooperative, and rest of the findings was within normal limit. On slit lamp examination, the pupil was 3 mm in size, reacting to light, but RAPT was absent in left eye. Visual acuity of the right eye was hand movement close to face, and it was 6/36 in left eye. BCVA was not improving in right eye, but it was 6/18 in left eye. Near vision was less than n/36 in right eye and n/10 in left eye. Color vision could not be assessed in the right eye, but it was affected in left eye. Ocular movements were full, free, painless in all directions of the gaze. Position and size of the eyeball were within the normal limits. On slit lamp examination, anterior chamber globe and adnexa were within normal limits. On posterior segment evaluation, media was clear, size and shape of the disc was normal, but a slight temporal pallor was noted. Margins of the disc were well lineated, but bony spicules presented at macula, macula and juxtapapillary area was noted. Mild arteriolar attenuation of the arteries was also noted. Investigations we did in the patient's ward, ultra-wide field fundus photo, OCT macula and multifocal ERG. As we can see on this ultra-wide field fundus photo, the
Pragya, please go to screen share.
नीचे में एक आइकॉन है, दिस आइकॉन, और ऊपर में एक आइकॉन होगा स्लाइड शो. On the top of your screen there is a slide show. Press that.
नीचे में आइकॉन है.
नीचे में भी है, ऊपर में लिखा हुआ.
Yeah, sure. Yes, that place.
Now, as we can see on this Optus photograph, the more of the center and juxta macula and juxta papillary area was involved instead of the peripheral retina, which is more commonly involved in retinitis pigmentosa. This was the fundus photograph we did in the patient. In the same also, we can see that the bony spicules were more over in the center as compared to in the periphery, because RP mainly involves the periphery first and then it comes to the center. OCT was done to check for any edema, for any central macular edema for which vision loss could also be there. At last, we did multifocal ERG, in which we can see that in both left and right eye, the amplitude of the P wave was decreased, but more amplitude was decreased in the right eye. Also, there was blunting of the central vision. Cones, this means that mainly the rods and cones of the central area were more affected. This is the multifocal ERG of the left eye. In there also there is blunting of the hill of vision, but it is less as compared to the right eye. So my provisional diagnosis for this case would be asymmetrical inverse retinitis pigmentosa. The differential diagnosis could be vitamin A deficiency, congenital stationary night blindness, retinitis punctata albicans, and self-settled retinal detachment. This is a case of a 22 years old male presented with diminution of vision in right eye more than left eye since childhood with illness and no similar complaints in the family. On examination, BCVA was hand movement in right eye and 6/18 in left eye. Anterior segment was within normal limit. On fundoscopy, both eyes show bony spicules involving macula, macula, and papillary area with slight temporal pallor and mild attenuation of the arteries. Treatment plan currently, there are no specific treatment modalities for this case. Only visual rehab can be given, refractive error correction can be given, and trial of low vision aids can be given. Prescription of glasses was given to our patient. Take home messages: retinitis pigmentosa typically presents with night blindness and peripheral vision loss, but this is a case of inverse RP which can affect central vision at a very early stage. As of now, there are no definitive treatment and only vision rehab is the key. Multiple research and advancement are underway for the treatment of the diseases. One of this is Luxturna, which is approved for RPE65 mutation, which is in trial for retinitis pigmentosa. Thank you.
To Pragya, you are on time. So judges, please questions to Pragya.
So, Dr. Pragya, that was a very nice presentation. And I would like to ask you that did you get genetic consultation or genetic evaluation for the patient? And what
Sir,
about
we
the
asked the
family?
patient, he said that there is no other family member affected with the similar complaints in the family. He was the first one who presented with like this kind of presentation.
So it could be a sporadic presentation of
Yes,
this
it
type,
could
or it could still be genetic, but he would have acquired the mutation in vivo maybe after the embryo would have started developing.
Yes,
So
sir.
in any case, if possible, get a genetic consultation done, because then it will have consequences, because you need to counsel the patient for because he's a middle-aged male. So
Yes, sir.
regarding the family also, you have to counsel the patient accordingly.
Yes, sir.
Thank you, Dr. Zahid. You are the next candidate. Will you please get ready? In the meantime, Dr. Anvita, are you here so that you can take up the questions? We have not asked you any questions. Dr. Anvita?
Yes, ma'am.
Yeah. So we have lost you in between. Your case was traumatic cataract. I will request
Yes,
judges
ma'am.
to ask questions to Dr.
Ma'am,
Anvita.
should I present it again? Because
No.
I guess in mid.
No,
Yes,
that's fine. That's fine. Judges
Okay,
can
ma'am.
take up the questions.
Okay.
So, Dr. Anvita, I would like to ask, what was the cause of traumatic mydriasis in your patient?
Ma'am, there was traumatic mydriasis, ma'am, because the iris was also injured. There was posterior synecdoche from 1 o'clock to 2 o'clock position.
Could you see any sphincter tears?
Yes, ma'am, sphincter tear was present.
Yes, that was the cause for a pupillary dilatation in your patient. And my another question
Yes,
is, how can you assess the posterior capsule preoperatively in such patients of intumescent cataract?
Ma'am, posterior capsule, ma'am, we should go for OCT changes, OCT, and through OCT maybe we can
Yes, you
see
can go
the.
for anterior segment OCT to see
Yes,
for
ma'am.
the status of posterior capsule, so that you can decide whether you will need to go for a PCIOL or you will have to go for an scleral fixated or an IOL, scleral fixated IOL. Okay,
Yes,
thank you.
ma'am. Thank you, ma'am.
Thank you. So, Dr. Zahid, are you ready? Dr. Zahid, are you there? Next candidate is Dr. Kunal Kumar. Please get ready. Dr. Zahid, are you here?
Zaid, Dr. Zaid, are you there?
Oh, sure, Dr. Zaid. Zaid, sorry. It's Zaid. Zaid Ashraf.
He's not there.
Okay, maybe he is absent. So, Dr. Kunal Kumar.
Dr. Kunal, are you there?
Yes, ma'am. Yes, sir.
Please start your slide.
Share your screen.
Yes.
So, who is presenting now? Zaid Ashraf?
No, ma'am, Dr. Kunal.
Please, Kunal. Dr. Kunal will be presenting.
Sure. Dr. Kunal will be giving a short bell after 5 minutes.
सेम तो खाने ये है एक मिनट
What happened, Kunal?
yes good afternoon
Hmm. Share your screen. Okay. Slideshow. Slideshow. Put it in slideshow. Yeah, downstairs. Yes. Okay. Start.
good
Your
afternoon
time
everyone
starts.
good afternoon everyone my case is a 48 years old male from Jamshedpur, Jharkhand, presented in MGMMCH IOPD on 8/9/2025 with chief complaint of redness left eye for 2 days, watering left eye for 2 days, irritation in left eye for 2 days, blurred vision for 2 days. History of presenting illness. Patient was apparently asymptomatic 2 days back. Then he developed redness in left eye in morning, which was sudden onset, not associated with pain. Then patient self-medicated with antibiotics containing preservatives. After 2 days, symptom worsened, causing blurring of vision and ocular irritation, for which he presented in OPD. And no such complaint in other eye. Past history. Past ophthalmic history. No history of ocular trauma, glaucoma, chemical injury, or any ocular surgeries. Past systemic history. No history of hypertension, diabetes, TB, cardiac disease, and GI disorders. Family history not relevant. Personal history. Mixed diet, normal appetite. Patient does no smoking, alcohol intake, or drug abuse history, and also no non-drug allergies. General examination. My patient was conscious and all oriented to time, place, and person. He was well built and nourished, of febrile. Vitals are stable and no pallor, ictus, cyanosis, and lymphedema present. Ocular examination. Head posture normal, facial symmetry maintained. External examination. Visual acuity of right eye is 6/6 and left eye uncorrected vision 6/18 and base corrected vision is also 6/18. Extraocular movement of both eye normal in all gaze. Salmer test done. Right eye 18 mm and left eye 22 mm. IOP left right eye 14 mm SG and left eye 12 mm SG. Conjunctiva of right eye are within normal limit. Left eye have diffuse congestion. Cornea right eye clear and in left eye there is corneal sensation normal, diffuse epithelial irregularities, a striae and DM that is decimal membrane fold and fluorescent stain positive. AC, pupil and lens of both eye are within normal limit. This is the image showing a decimal membrane fold and diffuse corneal staining. On fundoscopy, media of right eye is clear and left eye hazy. Optic disc of both eye are round in shape, normal in size, pink in color, healthy NRR, clear margin, CD ratio 0.3. Macula, both eye FR present. Blood vessels, both eye vessels arise from center of the optic disc, branching dichotomously into superior and inferior arcade with AV ratio of approx 2:3. Periphery within normal limit. Differential diagnosis. Toxic keratoconjunctivitis, infective keratitis, allergic conjunctivitis, neuropathic keratitis, and dry eye exudation. Case summary. A 48-year-old male presenting with complaint of redness, watering, irritation in left eye after topical use of antibiotic containing preservative for 2 days. On slit term examination, diffuse corneal epithelial irregularities and DM fold seen. Provisional diagnosis. Left eye toxic keratoconjunctivitis due to topical drug abuse. Treatment given. First of all, discontinue preservative containing eye drop. Then light patching for left eye for 24 hours. Eye drop moxifloxacin, which is preservative free. 1 drop 4 times in left eye for 5 days. Ointment azithromycin apply locally at bedtime in left eye for 5 days. Eye drop CMC 1 drop 4 times in left eye, which is also preservative free. Eye ointment panthenol twice daily in left eye for 7 days, tablet vitamin C for 15 days. And also patient educated about risk of self-medication, which is very much. And my follow-up after 3 days. Then visual acuity of left eye 6/12, IOP, left eye 14 mm SG, conjunctiva, congestion significantly reduced, cornea, epithelial irregularities markedly reduced, fluorescent stain positive at center of cornea. Same treatment continued and patient was asked for follow-up after 3 days. Thank you.
Thank you for being on time. So requesting judges, please ask question.
So, did you check for the corneal sensation in this patient?
Yes, ma'am. Cornea sensation is normal. Was normal.
Okay.
Dr.
Any
Kunal,
other question? Yeah.
Yes, sir.
I have one question for you.
Yes,
So
sir.
what about the anterior chamber of this eye? Were there keratotic precipitates or anterior chamber reaction was present?
No, sir. Enchanted chamber was quite, sir. Nothing significant seen.
Okay. And secondly, why didn't you give hometropine or any cycloplegic to the patient if there is keratitis or there is epithelial irregularity of the extent to which you have shown in the fluorescein staining? So it's always a better idea that you give cycloplegic also to the patient. Okay. Thank you.
Thank you. Dr. Issad, are you there? You are the next candidate.
Yes.
After Dr. Issad, Dr. Anamika Chaudhary, please get ready.
Dr. Ishad, are you there? Dr. Ishad? You can move on to Dr. Anamika. Anamika, are you
Yes,
there?
sir, I'm there. Yeah, Dr.
Dr.
Ishad.
Ishad is here. Dr. Ishad.
Okay, continue, Dr. Ishad.
Good afternoon, everyone. So my topic of the presentation is ocular chemical injury. Myself, Dr. Irshad Khan. I am from Kashyap Memorial Eye Hospital. So coming on to the case, my case detail is we have a 24-year-old male present with sudden diminution of vision in right eye. He has acute history of fall of battery acid water in right eye. Diminution of vision was sudden and due was associated with pain, redness, and watering and burning sensation. No other part of the body was involved due to this chemical injury. Past history is not significant, no systemic illness, and family history was not significant. On general examination, patient was conscious, oriented, and cooperative, and his BP and pulse was within normal limit, and other findings were normal. On examination, his visual acuity was 6/60 in right eye, and unaffected eye, that is left eye, is normal. On examination, his pupil size, shape, and position was normal. RAPD was absent, and intraocular pressure was slightly raised, that is 23. On the ocular movement was full free. Position of the eyeball and size of the eyeball was normal. On slit examination, we can see the conjunctival chemosis and congestion. There was a large epi defect, that is 6 mm epi defect with limbal ischemia and loss of palisades of bulbs that represent the limbal cell deficiency. Immediate treatment given was irrigation with normal saline for around 20 to 30 minutes. Now the question is when to stop the irrigation. We can measure the pH of the conjunctiva till the pH reaches 7. We have to continue our irrigation. After irrigation, we will apply the bandage contact lens, that is BCL. Post-stage second examination will be done later after the symptoms subsides. Now my provisional diagnosis, acute ocular chemical injury, grade 3. This grading is as per Roper Hall classification, which Roper Hall classification contains corneal involvement and limbus involvement. We also have a different classification, JHOS classification, that is more precise, and it contains 2-3 parameters like cornea, limbus, and conjunctiva. Initial management was done with topical steroids, antibiotic, lubricants, cycloplegics, anti-glaucoma, analgesic tablets, and vitamin C dominant tablet. And now patient comes after 1 week for follow-up. His vision is 6/60 and epi defect was slightly reduced. This is the clinical photo of first week follow-up. Then posterior segment evaluation was done and it was within normal limit. After that, patient comes after 3 weeks and his vision improved to 6/24, and now epi defect has reduced and he has mild stromal haze. And we ask the patient to continue the same medication. After this is the follow-up for third follow-up. Here we can see the haze is reduced. Now, after the patient lost to follow up and he came back after 6 months. He came back after 6 months with vision of finger count at half meter. We can see the 360-degree vascularization, deep and superficial vascularization with conjunctivation of the cornea and 360 pannus formation. His vision was finger count at half meter. And we asked the patient to start the topical steroids, antibiotic, lubricant. Now our diagnosis is chronic chemical injury, the stage 2B as per Holland-Mannis classification. Now our treatment plan is pannus removal with amniotic membrane grafting with simple limbal stem cell transplantation. This is a small video we have of intraop. Here we can see the pannus is separate from the first we will do the conjunctival peritomy. Then pannus will be separate from the conjunctiva and the cornea using the forceps and Vanna scissor. Here you can see the pannus is getting separated from the cornea. Then we will see the clear cornea beneath the pannus. Then next step will be we will take amniotic membrane graft and we will place it over the cornea. This is the amniotic membrane graft. It is placed over the cornea and it is sealed with the glue. Then after we will take the cadaveric tissue and we will take small biopsy from the limbal stem cells and we will cut into small pieces and will be placed on the cornea on the limbal area. And this is the intra photo of after the pannus removal. Here we can see the clear cornea and glow. Then this is the photo after amniotic membrane grafting, and this is another photo of after the limbal stem cell transplantation is done. So after the post-op, a patient comes after 2 weeks. His vision significantly improved from finger count at half meter to 636. And now on finding, this is the B cell is institute limbal stem cell. This is the post-op photo. Limbal cells particle are visible and corneal haze is reduced. Now patient comes after 4 weeks. His visual acuity is now 618 parts. From finger count, it significantly improved till 618 parts. So chemical injuries of 2 types, acid and alkali. Alkali is more dangerous than acidic. And slide is a technique involving a transplantation of small limbal biopsy from the healthy eye or cadaveric eye, and that allows the regeneration of the corneal epithelium. And in this case, there is a combination of pannus removal and slide led to the reepithelialization and visual improvement. So this case highlight the AMG provides immediate healing support and simple limbal stem cell transplantation help in definitive visual outcomes. So early recognition and timely surgical intervention helps in crucial, and that is crucial for the optimal outcome. Thank you.
Thank you, Dr. Irshad. You are on time. Please judge this question.
So wonderful case, Dr. Irshad. Just one question. How much clock hours of limbal stem cell injury was there?
Ma'am, more than 3 clock hours.
More than 3 clock hours. So that's why you classified it as what grade of Roper Hall?
Ma'am, grade 3. Roper Hall grade 3. Like in Roper Hall, we consider like more than one third to half of the limbus was involved. And if more than half of limbus is involved, then it is grade 4.
Okay.
Very well presented case, Dr. Irshad. One question to you that something something else would have been done in the immediate presentation so that the chronic phase would have been avoided. Anything else other than the topical medication that you had used?
Yes, sir. We could have placed the amniotic membrane graft for proper healing.
Okay, so amniotic membrane as well as even your autologous serum can also help in.
Yes, sir. Yes, sir.
Thank you, Dr. Irshad. We will be going to Dr. Anamika. Anamika, are you ready?
Yes, ma'am, I'm ready.
Sure, perfect. Next is Dr. Amar. Please get ready. So Anamika will be giving a short bell at 5 minutes. Then 6 minutes is the full bell.
Yes. Good afternoon, one and all present here. I am Dr. Anamika Chaudhary and I am here to present a case. A 19-year-old female from Hazaribagh presented to our OPD with the chief complaints of blurring of vision in both her eyes since the last 3 months. My patient was apparently asymptomatic 3 months back. Then she noticed gradual, progressive blurring of vision which worsened with time. There was no history of pain, redness, or photophobia, no history of recurrent attacks. She is immunocompromised due to HIV and is on ART for the last 6 years. There's no history of diabetes, TB, sarcoidosis, or rheumatological diseases. No history of trauma. Both her parents are HIV positive, and she belongs to lower socioeconomic group. General examination and systemic examination was within normal limit. Coming to ocular examination, in right eye, the uncorrected visual acuity and the best corrected visual acuity was finger counting at half meters, and in left eye it was 636. IOP by NCT was 15 millimeter of mercury and 12 millimeter of mercury respectively. Conjunctiva normal. In cornea, in both the eyes, we can see medium-sized, multiple, stellate-shaped, diffuse keratic precipitates present all over the corneal endothelium. But the corneal sensation was normal. Anterior chamber was of normal depth, but cells 1 plus and flare 1 plus was present in both the eyes. In both the eyes, there was diffuse iris atrophy with loss of iris crepes, and nodules were also seen, but there was no posterior synechia. The pupil was round, regular, and reactive to light. In right eye, mature cataract, and in the left eye, posterior subcapsular cataract. This is the corneal diagram of my patient. These are the anterior segment photos which we have taken with the help of a slit lamp and mobile phone camera. We can see the diffuse keratic precipitate distributed all over the corneal endothelium. These are the stellate KPs, as we can see from the diagram. There was diffuse iris atrophy in both the eyes, and iris nodules were also present. Right eye, mature cataract, and left eye, posterior subcapsular cataract was present. So fundoscopy was done. Right eye, there was no view due to mature cataract, and in left eye, vitreous membrane was present. Gonioscopy was done. It was open angle grade 3 in both the eyes with no hyperpigmentation, no posterior synechia, but Amsler's sign was elicited during paracentesis. Here is the Amsler's sign. On application of pressure with the 2-mirror gonial lens, we can see that the iris vessels, they started bleeding, as evident from the picture. So my differential diagnosis are Fuchs heterochromic iridocyclitis, Poshner-Shultzman syndrome, herpetic uveitis, and chronic anterior uveitis. But my provisional diagnosis is bilateral Fuchs heterochromic iridocyclitis with right eye mature cataract and left eye posterior subcapsular cataract. So we planned for right eye phacoemulsification PCIOL followed by left eye surgery after 15 days. The investigations were done. Keratometry was done, and IOL power was calculated using A-scan. So under PA, right eye phacoemulsification plus PCIOL was done with a single piece acrylic IOL. Post-operatively, she was started on eye drop moxifloxacin 0.5% plus prednisolone acetate 1%, starting from 6 times daily and tapered accordingly. Eye drop nepafenac, eye drop carboxymethylcellulose, ART was to be continued, and tablet dicyclophenac SOS. Follow-up post-op day 1, her uncorrected visual acuity was 6.9, and the IOP by NCT was 13 millimeter of mercury. Conjunctiva normal, cornea, stellate KPs present, cells 2 plus, flare 1 plus, and the IOL was well in place. Post-op day 14, her best corrected visual acuity was 6.6 with an addition of minus 0.25 diopter cylinder at 180 degrees, and for near, she was given plus 2.5 diopter sphere. IOP was normal and the IOL was in place. For left eye, this is the video which we have shown that we have done phacoaspiration plus PCIOL, and at the end of the surgery, we can see that after AC paracentesis, there's collection of blood, which is the Amsler's sign, very much suggestive of Fuchs. Post-operatively, she was started on the same medications. Follow-up post-op day 1, left eye, her uncorrected visual acuity was 6.6 partial. IOP by NCT was 12 millimeter of mercury. Anterior chamber cells 2 plus, flare 1 plus, air bubble was present, and IOL was well in place. Day 14, she was plano 6.6, but for near, we have added plus 2.5 diopter sphere. IOP was normal, and the IOL was in place. This is the final visual outcome of my patient. Everything was within normal limit, and the IOP was also well controlled. So she was a happy patient as her vision got restored. So as we all know that Fuchs heterochromic iridocyclitis, also known as Fuchs uveitic syndrome, is a rare and a chronic form of uveitis that primarily affects one eye. But there have been cases which have shown bilateral occurrence of this disease as well, but that is very rare. To the best of our knowledge, this is one of the first cases of bilateral Fuchs uveitis reported in an HIV positive patient. Because it is easily misdiagnosed due to non-specific signs and symptoms, it can be vision threatening, especially if effective treatment is not provided at an early stage. Thank you.
Thank you, Anamika. You are on time. So,
Thank you,
judges,
ma'am.
please ask your question.
So wonderful, Dr. Anamika. It
Thank
was
you.
good to see handmade diagrams, and
Thank you, ma'am. Thank you
and
so
I
much.
really emphasize that instead of putting photographs, residents should draw hand diagrams as they
Yes, ma'am.
they have to do it in their exams also.
Yes, ma'am. Yes.
So great. And Dr. Anamika, I have just one question, though
Yes,
it's
ma'am.
not pertinent to your case, but in uveitic cataract, what is the classical appearance of complicated cataract?
Ma'am, generally in complicated cataract, one C which we see is that there's a posterior synechia present, and the cataract it is generally of mature category grade only. And it starts. There can be also absorbed cataracts if uveitis has occurred because of trauma, or generally it is a secondary cataract which has occurred. And in cases of Fuchs uveitis, we mostly see it starts with posterior subcapsular cataract, and it progresses in way and can be mature forms, and total white cataract have also been seen in such patients.
So, any specific finding in posterior subcapsular cataract secondary due to uveitis?
Uh,
Any
Ma'am, it is
specific
generally of
appearance or something you can see?
grade 4, PSC grade 4 according to the LOCS grade 3. LOCS classification, it is usually PSC grade 4 which we see. And
So, so we usually see a breadcrumb appearance
yes,
or a
ma'am, breadcrumb
polychromatic
appearance.
luster.
Yes, yes, ma'am. Yes,
Yes,
ma'am.
correct. Okay.
Thank you.
I have one question to Dr. Anamika.
Yes, sir.
What was the CD count of this patient?
Yes, ma'am. So she was already on ART for the last 6 years. So her CD count was 800. It was above 500 because the titers were also well maintained as she was taking her ART dosage accordingly and following the rule.
So this association of HIV and Fuchs is a mere coincidence, I would say. And
Yes.
do
Yes.
you know any other causes or infective causes
Yes,
of uveitis in HIV patients?
yes. So she was also rubella IgG was positive in her, and as we all see the torch profile, generally rubella, cytomegalovirus, or herpes simplex virus have been seen to be associated with Fuchs uveitis. Though it is not a confirmatory, but there have been incidences in most of the cases, especially in the eastern zone. It is due to rubella, and Western countries it is due to CMV virus.
Thank you.
Thank you.
Thank you. Dr. Amar, are you there? Next is Dr. Gangadip. Please get ready. Gagandip.
Morning, everyone.
On slideshow. Yeah.
Dr. Amar, please start.
Good morning, everyone. Myself, Dr. Ravar Kumar, PG first year from MGM College and Hospital. My patient, 44-year-old male from Mango, Jamshedpur, came to OPD with complaint of sudden painless vision loss and blurring or distortion of right eye. My patient was apparently symptomatic since 1 week. Then he developed sudden painless diminution of vision in the right eye. No history of similar episode in the past. No history of floaters. In past medical history, known case of hypertension since 1 year and currently on medication, and known case of chronic kidney disease since 1 year and patient on hemodialysis since 1 year, and no history of diabetes and cardiovascular disease. In past ocular history, there is no history of trauma or ocular surgery, and there is no family history. In personal history, appetite was normal, bowel bladder was regular, and in social history, middle class socioeconomic group. In general examination, my patient was alert, conscious, and well oriented to time, place, and person. And obese, and patient was obese, pallor icterius cyanosis was absent, and on blood pressure was on higher side, 160 upon 90. And on systemic examination, there is all are within normal limit: cardiovascular, respi, central nervous system, and GI system. And in ocular examination, visual acuity, uncorrected visual acuity in the right eye was 618, and best corrected visual acuity is there is no improvement, and near vision plus 1.5 diopter cylindrical, and vision is innate. And in ocular movement, globe position, size, lid adnexia, conjunctiva, cornea are all within normal limit, and cornea was clear. In anterior chamber, normal depth was seen, iris normal, and pupil normal, lens clear, and IOP 14. And on gonioscopy, there is no neovascularization of iris, and iridocorneal angles were open. and in left eye there is all are within normal limit. This is my fundus picture in which media was clear and oval in shape. My disc was oval in shape and normal in color, and CD ratio 0.4. Neuroretinal rim was healthy and margin was blurred at the superior pole. And macular apha dull and macular edema appear as fluid pocket and flame-shaped hemorrhages seen in superior temporal quadrant. In blood vessels, dilated tortuous veins are proximal to the AV crossing and narrowing of the AV ratio. In periphery, there is a bed-shaped distribution of intraretinal hemorrhages, superficial frame-shaped and deep blot hemorrhages in superior temporal quadrant. And in left eye, there is all are within normal limit. And these are the investigations which are done, and all are within normal except BP was on higher side on when patient come 11/9/2025, 160/90. And in RFT, patient was dearranged. Serum urea and creatinine are on higher side, 150, and serum creatinine 6 mg per dl. My differential diagnosis was branch retinal vein occlusion, hypertensive retinopathy, and central retinal vein occlusion, and macular telangiectasia. And this is my OCT findings. Vitreous and vitreoretinal interface appears to be normal, and altered foveal contour, and increased central corneal central thickness, central macular thickness, increased central macular thickness suggestive of macular edema, and hyporeflective spaces are seen. Outer retina was in normal limit, and hyporeflective spaces are also seen between neurosensory retina and RPE, and RPE and Bruch's complex was intact. My provisional diagnosis was right eye superior temporal branch retinal vein occlusion with cystoid macular edema in CKD patient. Management was given as patient has been planned from intravitreal injection anti-VEGF, and eye drop nepafenec 1 drop 3 times was given, and treatment of the underlying cause was also given in the medicine OPD in our college, and patient was advised for follow-up after 1 week. And patient is currently under observation and monthly follow-up. Thank you.
Thank you. You are absolutely before time actually. So judges, please have your questions.
So Dr. Amar, which quadrant is most commonly affected in BRVO and why?
Most commonly present superior temporal quadrant because of
Like in your case.
because ma'am numerous AV crossings are present at that site.
Right.
Arteriovenous crossings are present.
So why not did you say that BRVO is secondary to hypertension? Why in diagnosis it is CKD?
Ma'am, in hypertensive, ma'am, there is a diffuse and bilateral type of finding. Diffuse retinal hemorrhages are seen in this in BRVO. There is a superior only one quadrant is seen and not the.
I mean to say you are saying BRVO secondary to CKD.
Yes, ma'am.
Why not BRVO secondary to hypertension?
Ma'am, actually, patient is on hemodialysis, and patient reports are also mentioned that the patient was treated since 1 year for hemodialysis in our college, and that's why ma'am it is related to CKD.
But increased BP is the cause for BRVO, no?
Yes,
in
ma'am.
your patient, BP was raised, no?
Yes, ma'am.
So hypertension can be because of kidney disorder. It can be linked to that.
Maybe a cause of in chronic cases. Maybe it is a case of actually patient came on 9 this September 9th, ma'am. That's why regular follow-up was also considered. Patient was also come in near.
Okay.
We can go ahead to the next presenter.
Any other questions? Or we can move to next candidate.
We can
Dr. Gagandip.
Am I audible?
Yes, but you're not visible. Yeah, correct. Start.
Put it on slide share.
Right. Shall I? Good afternoon. I'm Dr. Gagandeep Singh Gulati, here to present on herpes zoster ophthalmicus, a case series. A 45-year-old male presented with burning type of severe pain over the left side of the forehead and around the left eye since 5 days. Painful lesions on the left side of the face and forehead associated with itching since 3 days. Mucopurulent discharge from the left eye since 3 days. DOB left eye 2 days. Fever since 7 days. Had a history of chickenpox at the age of 10. Normal blood pressure and pulse rate, while the temperature was increased to 99 degrees. There's no history of immunosuppressive drugs. As we can see, there has been erythematous maculopapular skin lesion on the left side of the forehead and left upper eyebrow. The best corrected visual acuity of the left eye was 6/9. Intraocular pressure was 13. 4 millimeters after 1 minute of Sturmer's test. Ocular motility was full, free, and painless. While there was no problem, while the right eye was within normal limit, there was congestion in the conjunctiva in the left eye, mucopurulent discharge, cornea was clear, avascular, few chaotic precipitates over the endothelium, Epstein was negative. In the anterior chamber, few KPs were there, but there was no evidence of aqueous fluor or any foreign body. Equal round regular reacting normally to light pupil was present when reacting to accommodation as well. Lens was clear. On diagnostic evaluation, visual field testing was done, which showed no involvement of the optic nerve. Anterior segment OCT showed few hyperreflected deposits, suggestive of keratic precipitate. Ultra-wide field fundus photo was done, which is shown in the next slide. Lab test was done. CBC was within normal limit. ESR was increased. Viral confirmation was done with the help of Zank smear, and patient was HIV negative. The fundus for ultra-wide photograph of the fundus was within normal limit. Other case which I would like to answer the systemic treatment which was given were acyclovir and carbamazepine. The antiviral and the carbamazepine was given for the pain. Cold compression was advised at bedtime. Local and topical treatment, we gave moxifloxacin eye drop, prednisolone acetate, lubricating eye drop, and lactocalamine lotion. Moxifloxacin was given for other superimposed infection. On 12-day follow-up, the pain had decreased significantly, congestion and discharge had resolved, KPs had resolved, maculopapular region started resolving, BCVA improved from 6.9 to 6.6 partial. The other case I would like to present is a 65-year-old female complaining of severe burning type of pain on the right side of the forehead around the left eye since 15 days, painful lesion over the right side of the face, forehead, and the skin of the nose since 12 days, DOB right eye, double vision, drooping of the right eyelid since about 7 days, has a history of chickenpox at the age of 8, no abnormalities in the blood pressure, PR, or temperature. On ocular examination, the right eye unaided visual acuity was 1/60, left eye was 6/18. IOP was 19 in the right eye, 11 in the left eye. On external examination, there was pustular and crusted lesion on the right side of the forehead, right upper eyelid, and on the side on tip of the nose, which was a Hutchinson sign present. Ocular motility was restricted in all gazes and painless. There was severe grade ptosis. There were on slit lamp examination, conjunctiva showed severe congestion. Cornea showed epidefect in the inferior quadrant, decimate membrane fold, few fine keratic precipitates on the endothelium. On F-stain, large epidefect was seen. Anterior chamber showed no evidence of aqueous flare. Pupillin iris, in the pupillin iris, fixed non-reactive to light pupil was seen, and posterior synecdoche was appreciated. Lens showed immature senile cataract. This is the F-stain, which showed large epidefect. Other details of the posterior segment were not visible. On diagnostic evaluation, VFA was done, which could not be assessed because of high level of cataract, and also the patient was not that much willing. Anterior segment OCT showed few hyperreflective deposits noted on the posterior corneal surface corresponding to precipitates. OCT macula was within normal limit. There was no evidence of edema. MRI brain showed no space-occupying lesion. Routine tests were done in the laboratory tests. CBC showed lymphopenia. ESR was raised. Zank smear showed multinucleate giants, and HIV status was negative. The systemic treatment, acyclovir, 800 milligram 5 times a day for 15 days, then 2 times to continue. Carbamazepine, 200 milligram, 1 time at bedtime until pain subsided. Cold compress over the left side of the forehead. Local treatment, eye ointment of ganciclovir 5 times daily to continue. Eye drop moxifloxacin 3 times daily for 30 days. Eye drop of sodium chloride because of high level of corneal edema 5 times daily 30 days. Eye drop of propicamide phenylephrine at 1 time at bedtime was given for synechialysis. Lubricating eye drop were prescribed and lactocalamine lotion was given. After 7 days, the pain had significantly decreased, congestion was resolving, and BCVA of the right eye improved from 1/60 to 3/60. Further on, next follow-up would be done, and cataract surgery would be advised later on after the resolution of completely infection, after the complete resolution of infection. Thank you.
Thank you, Gagandeep. You are just on time. So, judges, please have your questions.
So, Gagandeep, wonderful case presentations. 2 different case scenarios of herpes zoster ophthalmicum, one with a Hutchinson sign and gross ocular involvement. So, just one question to you. Have you heard about zoster vaccine?
Yes, ma'am. There has been a zoster vaccine which has been available since 2017. Shingrix was the name, and 2 doses are recommended in a immunocompetent individual below the years of below 50 years, and not affected by the virus yet. Not affected by herpes zoster ophthalmicus, yes.
So usually we give it to elderly patients, not less than 50, but more than 50. And even those who had
Right,
an
ma'am.
attack in childhood, they can also be given to prevent the attack.
Right, ma'am.
Good.
Dr. Gulati, very nicely presented cases. Could you tell me what are the side effects of oral acyclovir that you have given to the patient in such high doses? What could be the possible side effects?
We have to check the liver function first because it is a hepatotoxic drug and nephrotoxic as well. So that has to be checked.
It has to be checked on follow-up as well, and it is
Yes, ma'am. Yes, sir.
it is nephrotoxic and not hepatotoxic.
Correct.
Thank
you. So, Dr. Adarsh, next candidate, are you available? Or next is Dr. Shubham Singh. Adarsh, are you there? Dr. Adarsh? No. So, we can go to Dr. Shubham Singh. Dr. Shubham, are you there?
Yes, ma'am.
Sure. So, you are Dr. Shubham Singh, right?
Yes, ma'am. Yes,
Okay.
ma'am.
Perfect. Please share your screen.
Dr. Neha, be ready.
Dr. Neha Chaudhary.
Dr. Adarsh is from MGM.
No, ma'am. Neha is from MGM.
Okay, then you can take Shubham Singh.
Yeah, Shubham, your time starts now.
Good afternoon, everyone. I'm Dr. Shubham Singh, presenting a case of a 35-year-old female using glasses since 10 years, presented with acute DOV in both eyes with present glasses since 1 day. Her DOV was associated with pain and watering, and there was no history of any trauma, surgery, or any pre-existing ocular disease. Her general examination was within normal limits. Her uncorrected visual acuity was 460 in right eye, 360 parts in left eye, and with current glasses, it was 660 parts in right eye and 560 parts in left eye. Her BCA was 6.6 and 6.9 in both eyes. On slit lamp examination, lid, globe, conjunctiva were normal. Cornea was clear. There was no RAPT. Her fundus was disc healthy and it was not dilated in view of extremely shallow anterior chamber. The pressure was high in both eyes, 45 being in right eye and 46.5 in left eye. On Van Harris grade on slit lamp, both eyes were grade 0, which means angle closed. These are the video of gonioscopy, in which there was a positional closure, which was observed on primary position, which opens up on manipulation. It was a scan showing shallow AC and closed angle. The lens thickness and axial length were within normal limits, but the anterior chamber depth was low. With it, we can rule out microsphere of AKR due to normal lens thickness, and there was no high myopia because of normal axial length. So my DDs were pseudomyopia, primary acute angle closure glaucoma, uveitis, ciliary body tumor. On asking further, she told she was using topiramate for severe headache since 10 days. So my provisional diagnosis was topiramate-induced pseudomyopia with secondary ocular hypertension. Patient was administered mannitol 300 ml IV stat and was prescribed following medications to control IOP: glycerol, ripasudil, brimonidine, timolol, travoprost, dorzolamide, and atropine. Cessation of topiramate was advised in consultation with a neurologist. On day 2, patient was symptomatically much better. Her IOP in right eye was 18 and 23 in left eye, and 40 mg Weissman OD was prescribed to reduce ciliary body inflammation and also to relieve accumulative spasm. Other medications were continued as prescribed. On day 3, there was no new complaints. The pressure was 10 in right eye and 11 in left eye. Brimonidine and timolol were stopped. Rest were continued as same. On day 10, her BCD was 6 both eyes and IOP was normal. Atropine and dorzolamide were continued and the rest of the medication was stopped. On day 17, both the BCVA and IOP was normal and all the medications were stopped. There was a decrease in refractive error from day 1 to day 17. On day 1 being -5 spherical in right eye, and on day 17 in right eye it was -2 spherical. And it was -4.5 in left eye, which decreased to -1.5 on day 17. So glycerol and mannitol shrinks vitreous volume, which causes posterior displacement of iris lens diaphragm. That is how it rapidly controls IOP. For long-term control, ripasudil increases aqueous humor outflow, brimonidine decreases aqueous humor production and increases UV scleral outflow. Timolol and dorzolamide decreases aqueous humor production, and atropine paralyzes the ciliary muscle, relieving the accumulative spasm. Topiramate is a sulfur-derived anticonvulsant drug often used in migraine prophylaxis. It causes ciliary choroidal effusion. Fluid accumulates in the suprachoroidal space, and it causes anterior rotation of ciliary body, which and it causes a shallow anterior chamber, secondary angle closure, myopia shift due to anterior movement of the lens, increased IOP, and it also causes increased IOP due to angle, low angle, narrow angle. These are the other sulfur drugs which also falls within the sulfur-derived drugs. Thank you.
Actually, you are before time, so very good. So judges, please go for your next questions.
Nicely presented case, Shubham. So what was the indication for starting topiramate in the first place?
Severe headache, sir. It was started because of severe headache, one-sided headache. It was started in consultation with a neurologist, as the patient said, and she was using it for the last 10 days.
Thank you.
Any other question from judges?
No, we can
Neha
move to
Chaudhary.
second line.
Yes, ma'am.
Yeah, you are ready. Dr. Shweta, you were asking some question?
I was just suggesting that we can move to next presentation.
So Dr. Neha Chaudhary, please
Yes,
start your presentation.
Yes.
Share your screen. Dr. Payal Sarkar, please get ready for your presentation after Dr. Neha. Then after Dr. Payal, Dr. Divya.
Can I start? Hello.
Yeah, start your
Start.
presentation.
Start.
Good afternoon, all. I, Dr. Neha Chaudhary, first year PG resident from MJ Medical College, going to present my case. Case scenario: a 23-year-old male from Jamshedpur came to OPD on 10 July 2025 with chief complaint of right eye upper eyelid swelling since 5 years, drooping of right eyelid since 4 years, and diminution of vision in right eye since 2 years. My patient was apparently asymptomatic 5 years back, after which he developed swelling over the right upper eyelid, which was progressive, gradual in onset, and of size 4 into 2 centimeter at the time of presentation, and it was not associated with pain and redness. Patient also presented with drooping of right eyelid, which was gradual in onset and progressive since 4 years with no diurnal variation and diplopia. Patient also presented with gradually progressive painless diminution of vision from right eye since 2 years, and it is associated with watering of eye on and off. Patient also gave history of macules and patches over the trunk. Past history. Past history of ocular disease. My patient had a similar history of swelling 11 years back, which was associated with drooping of eyelid in right eye, for which surgical removal was done 7 years back. There is no systemic illness present. In family history, patient father had a similar multiple discolored patches over trunk. In treatment history, patient is a known case of right eye upper lid plexiform neurofibromatosis, for which debulking surgery was performed 7 years back and was under post-surgical medication for 2 weeks. Biopsy was done post debulking and features of plexiform neurofibroma was diagnosed. In personal history, my patient was a student. He had a mixed diet and normal appetite, and no history of smoking and alcohol consumption was present. In general examination, my patient was conscious and well oriented to time place person, and vitals were stable, pill code was normal, and on head to toe examination, 7 to 10 cafe au lait spots of size more than 1.5 centimeter was seen. On ocular examination, head posture was erect, facial symmetry was symmetrical, and on external examination in right eye, distant vision was 6/6, IOP was 10 mm Hg. On extraocular movement examination, superior gaze restriction present, color vision was trichromatic, and corneal sensation was reduced. In left eye, all parameters were within normal limit. On ptosis evaluation, in right eye, MRD1 was minus 1 mm, MRD2 was 5 mm, interpalpebral fissure height was 4 mm, upper lid crease present, and LPS function was fair. And in left eye, all parameters were within normal limit. On slit lamp finding, in eyelid and adnexa, severe ptosis was seen. Eyelid was of S-shaped deformity. Diffuse swelling of size 4 into 2 centimeter was seen, and on palpation, it was of worm-like consistency. There was no tenderness present, well-defined margin, and having firm consistency. In conjunctiva, mild congestion was present. In cornea was clear. Anterior chamber was of normal depth. In iris, few lish nodules was seen, and pupil was sluggish reactive. Lens was clear. In left eye, all the parameters were within normal limit, but the iris has a few lish nodules. On fundoscopic examination in right eye and left eye, in both, media was clear. Optic disc is of normal size. CD ratio was 0.3, and in macula, foveal reflex is present in both eye. Blood vessels were of normal caliber in both eye, and periphery was of normal. In systemic examination, in cutaneous examination, cafe au lait macules was seen, and in CNS, there was no focal neural deficit was seen, and cerebral deficit was seen. My differentials were plexiform neurofibromatosis, capillary hemangioma, schwannoma, dermoid cyst, and recurrent calcium. The blood investigations were done, and all the parameters were within normal limit. In CT scan, hypodense lesion measuring 18 mm into 17 mm into 16 mm size was noted in sellar region with mild thinning of right parietal and temporal bone. In MRI brain, right sphenoid wing dysplasia with empty sella and bony thinning of adjacent craniofacial bone was seen. Herniation of right anterior temporal lobe into the orbit causing optic nerve displacement and orbital involvement was seen. And ill-defined enhancing soft tissue thickening was seen in right side. Case summary. To summarize my case, a 23-year-old male presented with right upper eyelid swelling, drooping of right eyelid, and diminution of vision in right eye with history of multiple cafe au lait spots in trunk. On examination, right eye had a visual acuity of 6/6 with superior gaze restriction, severe mechanical ptosis, ciliary congestion, few lash nodules were seen at iris, and having sluggish reactive pupil. My final diagnosis is right eye upper eyelid recurrent plexiform neurofibromatosis involving the orbital region. Plan for management, surgical management, transcranial orbitotomy of right eye with eyelid reconstruction, a multidisciplinary team approach involving the ophthalmologist, neurosurgeon, and oculoplastic surgeon, and medical advice, symptomatic management was done, and genetic counseling was also done. Other modalities like MEK inhibitors, selumetinib and tramitinib can be given, which is indicated in symptomatic inoperable plexiform neurofibroma, and it can cause a shrinkage of 70% up to 70% of tumor and may delay and reduce need for surgery. And debulking surgeries were indicated in a visual when there is a visual decline and progressive tumor growth involving a vital structure and progressive disfigurement or functional decline. Thank you.
Thank you, Dr. Neha. Questions, please.
Nicely presented case, Dr. Neha. Only one suggestion that always include a pedigree chart wherever possible. Okay, in your case presentations, since there is a positive family history and there is autosomal dominant inheritance pattern, do include a pedigree chart in your presentation. Thank you.
So, Dr. Neha, was gonioscopy done in your patient? So, what is the role of doing gonioscopy in cases with plexiform neurofibroma?
Actually, ma'am, lash nodules can block the trabecular meshwork and it can cause glaucoma. Maybe to see the anterior chamber there.
Now, many times there is goniosynecia and there are chances of glaucoma in such patients, and we must always take into account glaucoma in these patients. Was your patient having any sort of amblyopia?
No, ma'am.
So that also must be carefully looked into, because many times it starts in childhood and they have drooping of lid from childhood and that is missed.
Yes, ma'am.
Okay, Neha.
Thank you. So, Dr. Payal, are you ready for your case?
Yes, ma'am.
Sure, please start. Share your screen. Dr. Dibya, get ready for this is your next after Payal.
Share your slide.
Good afternoon, everyone. I am here to present a case. When the star fades, a case of neuroretinitis mimicking as optic neuritis. So the chief complaint, the 45-year-old male presented with complaint of right eye diminution of vision in the right eye for 3 months back. The patient was apparently well 3 months back, following which he developed sudden onset diminution of vision in the right eye for 3 to 4 days. It was gradual in onset and progressive in nature. The diminution of vision was painless and there was no history of vomiting or headache, fever, night sweating with rigor or weight loss or any history of trauma. He visited a local ophthalmologist who diagnosed it as a case of optic neuritis and was given 3 doses of IV methylprednisolone for 3 consecutive days. There was the medical history, no significant past history. He was a known case of hypertension, diabetes, IHD, cholelithiasis, and it was well under control and was under regular medication. He had a history of TB contact 15 years back. No significant past surgical history, no significant family history. General examination, the patient was alert, conscious, cooperative, and well oriented to time, place, and person. Average build. Other parameters were normal. Blood pressure was 128/90. A systemic examination was all within normal limits. Facial symmetry was symmetrical on both sides. External face normal, head posture normal, ocular position was normal, and ocular alignment was also central. On ocular examination, the right eye visual acuity without pinhole was FC at finger count at 2 meters. And with no improvement with pinhole, the pupillary reaction, right eye RAPD was present, extraocular movements was free and full and on direction of gaze, and no pain was associated with the movements. In left eye, visual acuity was 6/9 with improvement to 6/6 with pinhole. Pupillary reaction was normal and extraocular movements was also normal. So in the right eye, ocular admixture was with normal, ocular motility was also normal, and color vision, we could not read any of the Ishihara charts. Left eye was, all the parameters were normal. So in the right eye eyelid, in both right and left eye eyelids was flat, conjunctiva normal, sclera normal, cornea clear, anterior chamber was deep and quiet, iris was normal in color and pattern. He was phakic and the clear lenses were clear. On posterior segment evaluation, in the right eye, media was clear, vitreous was clear, optic disc, normal in size, the disc margins were blurred with peripheral hemorrhages, cup was obscured, macula was dull foveal reflex, and macular exudates were seen in the form of a star. Peripheral retina was normal, and tortuous vessels were noted. In the left eye, media and vitreous was clear, normal optic disc was normal in size, nasal margin was fuzzy, and CDR ratio was 0.4, macula was normal, peripheral retina and vessels were also normal. This is the fundus photograph showing the disc margins, which is completely blurred out in the right eye. And the exudates were seen in the macular area in the form of a star. This is the OCT of both the right eye and the left eye, and followed by the fundus FFA. So it was provisionally diagnosed as a case of fluororetinitis of the right eye. The treatment given, the patient was started on tablet prednisolone acetate 10 mg and was started on initially 6 tablets once daily for 1 week, and the doses were tapered accordingly. Tablet omeprazole for once daily for 6 weeks, and tablet calcium. On follow-up after 2 months, the visual acuity was improved from FC at 2 meters to 6/9 in the right eye, with no improvement with pinhole. Now the pupillary reaction was normal. All the extraocular movements was also normal. And posterior segment evaluation, the optic disc was normal optic disc was normal and with normal in size, with only the nasal margins was blurred. The macula was still, the foveal reflex was dull. So this is the 2 months follow-up photo in which we can see that few exudates were seen, but no macula star present. This is the OCT picture. So the plan of management, we ordered the following investigation for the patient: the viral markers, HBs, AG, anti-HCV, HIV 1 and 2, VDRL, TB gold interferon, MON2 test, toxoplasma antibody, and non-treponemal antibody, serum AC, serum calcium. So discussion, neuroretinitis refers to a combination of optic neuritis with signs of retinal inflammation, usually macular. The treatment should be specific to the cause, often consist of antibiotics, and often the recurrent idiopathic cases may require treatment with steroids and or immunosuppressants. The most common etiology of neuroretinitis is found to be 60% cases with cat scratch fever, idiopathic 25% cases, and other notable causes include syphilis, mumps, measles, herpes simplex and zoster, varicella, Lyme's disease, leptospirosis, toxoplasma, toxocara, and some inflammatory causes include sarcoidosis, SLE, Behçet's, polyarthritis nodosa, Takayasu, VKH, and inflammatory bowel disease. So we also have to keep some differentials in mind, such as the hypertensive retinopathy, papilloedema, anterior ischemic optic neuropathy, diabetic papillopathy, posterior vitreous traction, disc and juxtapapillary tumors, and toxic etiologies, including bischloroethyl, nitrosourea, and procarbazine. Thank you.
Judges, please, your questions. She has crossed a few seconds.
Okay, Dr. Payal, you have mentioned in your slide the first and the foremost cause being cat scratch, and you did not elicit any history of pet exposure or cat scratch in your presentation. So don't you think?
No, he didn't have any like pet or any.
So that was not mentioned in your presentation. That's what I mean to say. Go ahead, Dr. Shweta, you want to ask?
The same question. I was also having the same question. I think we can shift to next presentation.
I'll keep that in mind.
Okay, so presenter, please get ready. It's Dr. Divya.
Yes, ma'am.
Okay. Dr. Shreya Kaul, you are the next presenter. Please get ready. Dr. Sonia Ghosh, are you there? Dr. Sonia? Okay. So, Dr. Divya, please share your screen.
Okay, ma'am. My screen is visible?
No, not yet. You have to share your screen. You have not yet shared. Yeah, it's coming up. Please start.
Good afternoon, everyone. I am presenting a case report on. Hello, good afternoon.
Slide share. Yeah, it's all right.
Good afternoon, everyone. I am presenting a case report on golden hour syndrome. Case presentation: a 23-year-old male reported to the eye OPD with diminution of vision in both eye and a mass over both eyes since early childhood, as per history acquired by patient and attendant. On examination, right eye upper lid coloboma seen, epibulbar choristoma seen. Left eye epibulbar dermolipoma was seen. Preauricular skin tags were present. Micrognathia, maxillary hypoplasia, facial asymmetry, hemifacial microsomia was seen. He had cleft lip for which he had undergone surgery in childhood. This is the picture for the same. Right eye on ocular examination, right upper lid coloboma present, revealed a smooth and soft mass in the right eye, posterior limit of which could not be seen. From above downward, it was extending from the superior to the inferior fornix. Left eye epibulbar dermolipoma located in the inferotemporal region of the eye, arising from the inferior fornix. It was extending from the lower fornix to the limbus. These are the pictures. On palpation, mass was found to be soft, non-tender, and its temperature was not raised. It could be moved over the underlying structure, and conjunctiva over it could also be moved. His visual acuity was: right eye visual acuity could not be assessed, left eye 6/24 and corrected to 6/9. The rest of the anterior segment was normal. Fundoscopic examination was found normal. The clinical diagnosis was dermolipoma, which was confirmed on histological examination of an excised portion. ENT examination revealed preauricular tags present in both ears, micrognathia, maxillary hypoplasia, facial asymmetry. No other abnormalities were detected. Systemic examination like cardiovascular, pulmonary, and genitourinary system was done, but no abnormalities were detected. The laboratory examination were within normal limit. ECG was normal. Chest ray, no abnormality detected. X-ray of the vertebral column was normal. A diagnosis of golden hour syndrome was made, which is also known as oculo-auriculovertebral dysplasia. A few words in golden hour syndrome. It is a craniofacial syndrome, which means it causes certain abnormalities in the formation of face and head. It is a rare congenital birth defect resulting from the abnormal development of the first and the second brachial arches, with incomplete development of the ear, nose, soft palate, lip, and mandible. It is unilateral in 70 to 80% of the cases. Incident rate is 1 per 25,000 or 45,000 live birth. Male is more commonly affected than female. Risk factor: maternal intake of thalidomide, cocaine, retinoids, tamoxifen, anticoagulant result in hematoma in the region of the developing ear and jaw, which causes destruction of the differentiating tissue, leading to the brachial arc dysplasia. Maternal diabetes, bleeding in second trimester, malnutrition, exposure to tobacco during pregnancy, maternal and fetal hypoxia, and hypertension. Clinical features: facial abnormalities, hemifacial microsomia, one side of the face is smaller compared to the other, cleft lip or cleft palate, defect in eye, ears, and spine. Ocular anomaly occur in 50% of the cases. Epibulbar dermoid and lipodermoid are most common. Limbal dermoid and lipodermoid are mainly located in the inferotemporal region of the eye. Coloboma of the upper eyelid may be present. Ear extraocular defect are reported in 65% of the cases, and it includes preauricular tag, microtia, nausea, conductive hearing loss. Spine: incomplete development of the vertebra, fused, missing vertebra, scoliosis, hemivertebra, fused ribs, kyphosis, and scoliosis. Intellectual disability: additional features such as cardiac, genitourinary, and pulmonary symptoms can be affected. Diagnosis is mainly clinical, based on history and examination of the eye, face, and skeletal system. Prenatally, ultrasonic diagnosis may theoretically be done at the 11th to 15th week in utero. Newer imaging modalities such as three-dimensional ultrasound may help in detection of microtia, preauricular tags, and asymmetry of the mandible even in mild form. Hearing and vision tests, ASOCT, help to look for the depth of the lesion and corneal stromal involvement in planning of surgery. Ultrasound biomicroscopy is used to look for the depth of the lesion and involvement of the angle of interior chamber. X-ray of spine, imaging of a heart and kidney. Differential diagnosis: Preacher-Collins syndrome usually shows similar features with a bilateral presentation. Downey-Brooks syndrome shows additional thumb abnormalities, anal defect, renal anomalies, which are not seen in Goldenhar syndrome. Linear-nevus sebaceous of Jodashian shows additional features of cloudy cornea, verticutaneous lesion, infantile spasm. Chart syndrome is associated with the characteristic semilunar canal anomalies and cranial nerve dysfunctions, while mandibulofacial dystortions can be differentiated by esophageal atresia and microcephaly. Treatment: complex reconstructive surgeries or glasses, oculoplastic surgery to manage oculopalpebral defect, palpebral reconstruction, lamellar keratoplasty, amniotic membrane and limbal stem cell transplantation. Hearing aids, surgery to correct heart and spine defect, refer to hearing specialist or speech therapist. Educational specialist for intellectual disabilities. This is the picture before surgery and this is the picture after surgery. Tension flap or Cutler bread. It is a surgical technique used to reconstruct large upper eyelid defect involving a two-stage procedure. Stage 1, full thickness cutaneous conjunctival flap from the lower eyelid to fill the defect of the upper eyelid to provide coverage and support. Stage 3, performed 6 to 8 weeks later after the flap has vascularized. The surgeon then divides the flap pedicle, the lower eyelid tissue is returned to its original position, and the lid margin is repaired to restore full functionality and cosmetic appearance. Thank you.
I have only one suggestion, Dr. Divya. Try to make your presentation a little presentable by reducing the content in the slides and using appropriate fonts and headings. So that makes the presentation better. Okay. Can go to the next presenter. Dr. Shweta, you want to ask?
Hello.
No, we can move to next presentation.
Dr. Shreya, are you available? Shreya, call.
Yes, ma'am. Good afternoon, everyone.
Please share your screen.
Is my screen visible?
Yeah, put it on slideshow.
Your time starts now.
Good afternoon, everyone. My name is Dr. Shreya Kaul. I'm a PG first year doing my DNB ophthalmology at Manipal Ranchi. Courtesy for this case to Dr. Bikramjeet Pal. The title for my case presentation is Ocular Manifestation as a Primary Presentation for an Underlying Critical Systemic Disease. So for my case, this patient is a 32-year-old young male. He's a salesman by profession. His chief complaint was he presented with a bilateral, gradual, painless diminution and blurring of vision for 3 months. For the systemic history, he noted low-grade fever as what he was telling, on and off for the past few months, and mild weight loss was noticed by the patient. So this patient has taken a primary consultation elsewhere. He was initially diagnosed as a case of hypertensive retinopathy and was advised anti-VEGF injection in both eyes. For the past medical history, no significant history is being given by the patient, no significant family history has been given, and no comorbidities has been explained by the patient. For the past surgical history, intravitreal injection history has been given by the patient. He had been given those injections elsewhere, 1 dose in each eye. For the ocular examination, the visual acuity was noted for the best corrected visual acuity was noted as 612 in both eyes and N6 for the near vision, both eyes. Color vision was noted normal in both eyes, the intraocular pressure being 12 millimeter of mercury, both eyes. For the anterior segment examination, both eyes showed were unremarkable, no significant findings were noted. So now, till now, there is no significant finding noted. Then we proceed to the fundus examination, for which we did a fundus photo for both eyes. For the findings, we see scattered hemorrhages in all quadrants, multiple rod spots were noted in all quadrants, and perivascular whitish infiltrates were noted. These are the fundus photos of both the eyes for the patient. As we can see here, in these fundus photos, regarding the media is clear, the image is pretty clear. The optic disc, if we note, the margins are not really clear. We can note slight hyperemia in the nasal side of both the discs. For the arcade vessels, we can see there's tortuosity present. There is a little dilation also present. And there is a perivascular whitish infiltrate around all the blood vessels. The arrows point towards the classical appearance of the rod spots that were noted in the fundus photos. This is a montage view for this for the right eye, for the left eye, and same rod spots, extensive rod spots were noted throughout the fundus. So next step, we try to investigate. Our most relevant clue stays extensive rod spots being over the fundus here. In the investigations, the most significant finding that we could point out to was a complete blood count and a peripheral blood smear done for the patient, where we note that patient has low platelet counts and the characteristic finding of an immature blast cells present. Next step, we immediately go to an oncologist. We refer the patient to an oncologist. For the final diagnosis, the oncologist diagnoses the patient being in the blast crisis stage of the chronic myeloid leukemia. For the management, immediate treatment was started as was directed by the oncologist. These are some reference articles which mention that ophthalmic problems usually they can occur due to direct or indirect infiltration of the neoplastic cells. Although almost all structures could be affected, leukemic retinopathy is the most frequent clinical manifestation that could present to us. Another article that suggests that patients will present with bilateral subacute visual impairment. The fundal examination would reveal bilateral symmetrical leukostatic appearance with increased vascular tortuosity, diffuse retinal infiltrates up to 6 disc diameter size, retinal hemorrhage as a classic appearance of a rod spot. Another article that mentions that resolution of leukemic retinopathy, usually when the treatment, for example, imatinib therapy is started, it usually is seen in 6 months after the initial visit. The retinal hemorrhages would have resolved and remain so after 18 months, as suggested in this case. The takeaway from my case presentation would be a systemic condition could present as an ocular finding being the primary presentation to us. The eye necessarily becomes a window to an underlying case in these things. This highlights the role of us as an ophthalmologist in diagnosing the systemic diseases when ocular manifestations are the reason of the patient's first visit regarding the same. And a timely diagnosis in early to moderate cases could help initiate early treatment in such cases. Thank you.
Thank you, Dr. Shreya. You ended before time. Now the judges, you can take the questions, please. Any questions from the judges?
Dr. Kaul, what are rod spots?
Ma'am, rod spots are basically what they appear to us are like they have a white center with a periphery of hyperemic area. So in any condition where we have there's some in any condition where some glucostasis has occurred, in which some rupture of the capillary has occurred. So due to the endothelial damage, what will happen is that there is platelet coagulation cascade that gets activated. And due to that, there is a center of the infiltrate of cells. In leukemia, it will be the leukemic cells, and the periphery will be hyperemic due to the inflammation that has occurred.
Correct. Very good.
Dr. Shreya, the
Yes,
leukemic retinopathy that you have shown in this patient, is it more common to occur in acute leukemias or chronic leukemias?
So, sir, this kind of presentation more common will be in acute leukemia, but because this patient was eventually found to be in a blast crisis stage, which can mimic an acute leukemia stage of the patient.
There were certain pointers. Had the patient been evaluated previously, because the patient had fever and weight loss since 3 months. So if
Yes,
a
sir.
systemic evaluation would have been done previously only, then it would have been caught at that time as well.
Yes, sir.
Thank
Yes, sir. Thank you, sir. Thank you, everyone.
Now the next speaker is Dr. Sonia Ghosh. Are you there? Dr. Sonia? So with that, we end with this session, the paper presentation session. Now our next session is the guest lecture session. We'll announce the winner after this session. Madam Rashi Shyam will take over from here.
Doctor, I see two speaker left. Dr. Shrishti Shreya, उसका हो गया है. Dr. Sonia Ghosh.
Yeah, Sonia Ghosh is not. She's not present, madam.
अच्छा, all done ना?
Yes, ma'am, all done.
Okay, so now we have to start the guest session, but first you have to introduce them. Each speaker you have to introduce, then the guest speaker will give their talk.
So, good afternoon, everyone. This is the session 4, which is the guest lecture. We apologize for the slight delay we are running into, and we heartily welcome and thank our guest lecturers who have been present.
Stop. First, I have to introduce the coordinator of this session. Coordinator of this session is Dr. Rashi Shyam. She is trained in Shroff Eye Hospital, and she is a prolific glaucoma and cataract surgeon. And she is the coordinator, and she runs Kamal Eye Hospital in Ranchi, director of Kamal Eye Hospital Ranchi, and she is the coordinator of this session. So welcome, Dr. Rashi Shyam.
Thank you so much for your kind words, ma'am. So Dr. Shweta Walia and sir have been with us very patiently for the last few sessions, and we welcome you once again. I would like to introduce them before we proceed with the guest lecture topics. So Dr. Shweta Walia, ma'am, she is a fellow pediatric ophthalmology and strabismus from SNC Chitrakoot. She is currently chairman scientific committee of the Madhya Pradesh State Ophthalmic Society. She has more than 50 publications in national and international journals to her credit, and the innovative technique of sutureless glueless SFIOL in 2016 as well. There are many awards to her name, and to name a few, these are the All India Talent Search Scholarship Award by the then Prime Minister of India, Shri H.D. Devegowda sir. Best Teacher Award, Srimati Mani Harish Chandra Memorial Award. Winner of the Clash of Titans at Indore Annual Medical Publication Award, Naika Award, and Award of Excellence letter by Indore Collector and Minister Kailash Vijay Varghese during 26 January parade ceremony for the exemplary work done by her to promote eye donations in the city of Indore.
Thank you, Dr. Rashi and Dr. Bharti, for such kind words and inviting me over here. So today I'll be presenting few tips and tricks for IL-PAR calculation. We all know that cataract surgery is our bread and butter, and we all need happy patients every time. And they, on post-op day 1, all of us would be happy seeing our happy patient. And if the patient is gloomy and we have to prescribe glasses to him, it is a heartbreak to us. So surgery is an art, but accurate calculation is built on numbers, and we as being doctors are very bad at mathematics and numbers, but few tips and tricks can make us master of these numbers. So why IOL power calculation is critical? Because Good biometry gives us good outcomes, and all our patients demand an unaided 6x6 vision. And a small error of 0.1 millimeter in axial length calculation can amount to 0.25 diopter of refractive error, and to extrapolated 1 millimeter leading to 2.5 to 3 diopter of power shift. Similarly, in keratometry, a 1 diopter of error can amount to 0.9 diopter of IL error calculation. And if the effective lens position is not in the bag and is just 0.1 millimeter forward, and it will lead to 1 diopter of refractive error in the post-operative phase. So the surgery ends in OT, but the success continues in the clinic. So it was long back when IOL was started during the period of World War II. It was Harold Ridley who first implanted the first IOL. And that patient had a refractive error of minus 18 diopter with a large number of cylinder. So this is not acceptable these days, but it was at that time. And then Minkoff came up with a pre-pupillary lens, and he also had same refractive error. So this led to the some improvements and some IL power calculation, so that the patient doesn't have to wear such big number spectacle. And then Fyodorov came with a power calculation in which he incorporated axial length, refractive power, and anterior chamber depth. Now, when we are calculating IL power, we take into many parameters into account: the axial length, the K reading, anterior chamber depth, effective lens position, and the IOL constants. Also, few IL formulas have white to white corneal diameter also incorporated. So coming to the first keratometry, it measures the anterior corneal surface. We can do it manual, but it is very rarely performed. We can use autorefractometer. Optical biometer has incorporated inbuilt in it, and we can also use topography and tomography when we specifically need to have the posterior corneal astigmatism, and in patients having irregular astigmatism when we are planning incisions, and to assess the spherical aberrations. Now, biometer can be either an ultrasound or an optical. Ultrasound is usually contact and immersion. Immersion gives readings which are par excellence with the optical biometer. We can go for immersion if done properly, and it gives a result typical to the optical biometer. But optical biometer is superior as it gives a telecentric keratometry and true K values as it measures the posterior corneal surface also. And there is a fixation check also, because continuous B scans can confirm the foveal visualization for accurate axial length measurement. Now, many of us still are doing contact we are still on ultrasonic biometer, and it must be done most accurately. And in our medical colleges, the residents are doing this A scan, and for them, it can be done either in a seated or a supine position. When we are doing immersion, and the patient has to be in supine position, we have to put a topical anesthesia, give them a fixation target, and you have to touch the cornea without indentation, and you have to note down the echo spikes. The echo spikes have to be of 100% height, and they should be at 90 degree to the surface. So you can see over here that there are 5 spikes that can be seen in a contact type of ultrasound biometer, and all of them are having a high peak and are of good resolution. Now I am showing now another A scan over here. You can see that this spike is not 100%. So this scan you will delete from the 10 readings that are coming, and then you will again retake for recalculation. So all such, when we are doing biometry, you should see what type of spikes are coming. Now see this picture. Over here you can see that the first spike is having 2 spikes. So my question is it normal, or we have to delete it and take another? Rest all of the spikes are of 100% height and are of good resolution. So why this 2 spikes have come? Has anyone ever noticed this? Yes, most of us have noticed who are doing immersion ultrasound. And in ultrasound, both the cornea is giving spike for the epithelium and endothelium. And if you see these 2 spikes, it clearly indicates that this scan is immersion type. So this can be asked in their postgraduate viva also, and they must know the difference on the scans, whether it is a contact type or an immersion type of A scan. Now see the scan. Over here, you can see that excellent measurement has come 24.60 and another it has come 24.18. So this if difference is because of compression, and this slight difference has led to a refractive error of minus 1.25 diopter spherical postoperatively. So you must be very, very careful when you are calculating the A scan powers. Now over here you can see that the retinal spike is not perfectly straight. So that it means that the probe is not aligned properly, and this scan should be deleted and another scan should be taken. Now see here's a case of a 65-year-old male for routine cataract, and he has undergone contact ultrasound. The axial measurement was 21.2. Retinal IOL power was 22 diopter. However, the post-op result was plus 2 diopter hyperopia. So what has amounted to this? This is because that the cornea has indented and has led to false short axial lens. So compression of cornea should be avoided, and you should be very, very careful when you are doing to contact ultrasound. Now, most of us have now shifted to optical biometers, but we should be careful in those cases also. Now, this is a case too, and it is a 70-year-old male, and IOL master has given the readings, and the target achieved is 6/6. So what has worked, because the fixation is verified as in this optical biometer, the ocular surface is good, and we take a true K and anterior chamber depth and lens thickness is measured accurately, and that's why the patient has achieved a target vision of 6/6. But this patient, a 62-year-old female who is a diabetic, an optical biometer was done and predicted IOL power was 21.5. However, again, the post-operative result was plus 1.5 diopter hyperpopia. So what went wrong? So this is a diabetic patient, and diabetic patients usually have a dry eye, and this must be taken into consideration. The corneal surface, the ocular surface should be perfect. And in this case, because of dry eye, there was false steep case, and this overestimated the corneal power. So ocular surface optimization is very, very crucial. Now, dry eye symptoms can mimic cataract symptoms like glare, halos, and decreased vision. And surgery can worsen the dry eye, leading to patient dissatisfaction. So dry eye identification is a must before surgery. And if the patient has a moderate to severe dry eye, first we must treat the dry eye, inform the patient that he has dry eye, and post-operatively also he can continue with the symptoms. Now, this is another patient who is a myopic and has axial length of 28.5 millimeters. And an optical biometer was used, but still the patient is myopic by -2. So what went wrong? So you have to see what IOL formula you are using and what is the effective lens position. Many times the effective lens position changes, and this leads to a refractive surprise. So in high patients having high axial length, either a Barrett formula or a Von-Rich calculation must be done. So this is the case. Over here, you can see that the axial length in right eye was 24.48, while in left eye it was 25.71. So nearly 1.25 millimeter difference is there, and this can amount to a difference in the IOL power. So in right eye, the power came out to be 11.5, and in left eye, it came out to be 6. However, when we see the formula used, when you are using the Barrett, the power is coming to 7. And when you are using SRKT, it is coming to 9. So which formula to take? Now, in this case, we will see what are the K values of the patient. The K values are also not normal for this patient. In right eye, it is 46 and 48. In left eye, 47 and 49. So in such patients who are having large corneas, in those, even if the axial length is different, you must go for SRKT formula, and for this patient we'll go for 9 diopter, not for by the 7 using Barrett formula. Though Barrett is a universal formula that we can use at any time, but if the K values are abnormal, we must go for SRKT formula. So you must check with all the formulas what formulas are coming, what values are coming, and then take a call. So there has been evolution of IOL formulas from early approaches to regression formulas.
to theoretical formulas, to new novel formulas, the Barrett 2, the EVO, the Kane, Olson, and the Pearl formula. And for normal axial length, most of the formulas work well, while for short axial length, Barrett, Hills, and Higgins and Olson formula works well, while if the axial length is long, we usually go for Barrett, Hill, Higgins, Olson, SRKT, and also for a Wong-Kutch adjustment. What is Wong-Kutch adjustment? If the axial length, for increasing axial length, we have to subtract some amount, and this is done for long axial length patients. You can use various online calculators. The ASRCS formula, the site gives us various tools to calculate, and this is a wonderful site, and you can check your whatever formula power is coming with your A scan, put those readings over here and use new formulas. Now, when you are planning for toric IOL, you can use the online calculators and plan your incisions. Now, if there is an anisometropia, recheck everything. The formula should be matched for axial length, match the power with the spectacles, and select IOL power based on agreement across multiple methods. Effective lens position is a very important thing. Many times you have done everything correctly, but still the patient comes up with a refractive surprise. And this can be because of effective lens position change. Many times there is rent and you have to plan the lens into the sulcus. And at that time, this back sulcus algorithm comes to our help, and we can recalculate our power and place the lens into the sulcus. Now, what about the cases who have undergone some refractive surgery or a RK surgery? Now, this is a case of a post-RK patient with 20 marks. So in these, the K readings are unreliable, and biometry suggests widely different IOLs. Also, the K readings changes with dian variation. You have to select the flattest K, and target refraction has to be myopic. And you can use ASRCS post-RK calculator, and with the Barrett True K vac, you can get the IOL power. Similarly, for the post-LASIK patients, you can use the online calculators and use them. Now, in pediatric patients, for more than 6 years, we can use IOL Master. For patients between 3 to 6 years, we can attend for an IOL Master and confirm on A scan. For children less than 3 years who are uncooperative to sit on the machine, we can use immersion A scan under anesthesia. And since the pediatric eyes are smaller, we can use Barrett formula with Dahan's corrections. If the child is between 0 to 2 years, we undercorrect by 80%. For 2 to 8 years, 90%. And for more than 8 years, no undercorrection is done. We aim for emetropia. So counseling of patients is very, very important. The high-risk patients, that those are having short eyes, long eyes, undergone refractive surgery, or a keratoconus patient, we must be very, very careful. We should spend time in communication, discuss with them the refractive surprise that can occur, address the potential need for glasses, and show them calculation sheet. Also, explain them limitation of technology, discuss post-operative options, and consider two-step approach. So lens constant optimization is also very important. We all usually take the lens constant that is mentioned on the IOL, but we must validate it with our data, what surprises, what outcome you are getting, and you can use that A constant for them. You must stay current, read journals, attend meetings, watch webinars, join the communities. And whenever there is a post-operative surprise, review the initial calculations, biometry parameters, check for any surgical complication that had occurred. If there is significant residual error, consider for IOL exchange. For IOL exchange, remeasure when cornea is quiet, use multiple new generation formulas, adjust power for second eye based on first eye outcome which can improve the accuracy. And avoiding errors, you must put a checklist to confirm the patient ID, correct eye, IOL type, and power before the implantation. So you must be master of the fundamentals, understand the biometry principles and measurement techniques, use multiple formulas, no single formula work best for all eyes, recognize the special cases, continuously improve yourself, and stay current. Thank you so much.
Thank you so much, ma'am, for such a complete and detailed presentation, which will, I'm sure, help the PGs as well as all the consultants who are watching us today.
Oh, it is helpful to me also. It is so good. And it is so simple and so practical. It is really very nice.
Shweta is always
Very
good.
good.
Thank you so much, sir. Thank you so much.
I would now like to welcome Dr. Devesh
Actually,
Mahawat.
yes. Do
So,
it.
sir is an assistant professor in Dr. R.P. Center Ophthalmic Science Institute of AIMS. He has been a graduate as well as he's done his post-graduation from there, and he's an FRCS from Glasgow also. He has been assistant editor of Delhi Journal of Ophthalmology and examiner in FRCO and FECO. Now, there are many awards and recognitions due credit to him, and Dr. Bodhraj Sabharwal Gold Medal Award, Elergan Academic Achievers Award, Dr. V.K. Kalra Memorial Trophy Award, Certificate of Merit from IJO in 2021, and a Gold Award in 2023. AIOS International Heroes Award in 2023, Best Poster Award for Trauma category in AIOS APAO 2025, and Dr. Arjun Narang Award for the Best Paper Presentation in Annual DOS 2025. There are more than 85 publications to his credit, and he has been an editor of the educational book on diabetic retinopathy by ARC AIOS also. We welcome you, sir, and can you please proceed now?
Thank you for the kind introduction. Is my slide visible?
Visible.
Okay, so I'll be talking about tips in the management of diabetic tractional retinal detachments. So what are the management options that we have for diabetic tractional retinal detachments in a diabetic patient? So mostly we undertake these patients for vitrectomy when the macula is involved in the tractional retinal detachment, as we see in this photograph, that there is an extensive tractional retinal detachment which is involving the posterior pole. Or if the macula is threatened by the tractional retinal detachment, as we see in this image, there is a tractional component of detachment you can see along the supratemporal arcade. There is fibrovascular proliferation at the disc, nasal to the disc, and along the supratemporal arcade as well. And along the supratemporal arcade, you have a tractional retinal detachment, which is not directly involving the macula, but yes, it is threatening the macula and it is causing some striae on the macular area, and therefore the macula is threatened and you need to operate these patients so as to preserve their vision. Now, what about observation alone? So observation can also be one approach in extramacular tractional retinal detachments, because often these tractional retinal detachments which are extramacular or outside the posterior pole remain stable. And if the patient is compliant enough to follow up, then you can observe these patients. Like we see in this photograph, there is extensive fibrovascular proliferation nasal to the disc and along the inferotemporal arcade, but it is not involving the foveal center. And if the patient has stable vision and is compliant to follow up, then you can observe these patients. Now, what are the pre-operative considerations that you should make before taking these patients for surgery? First and foremost is the metabolic control, wherein you need to control the blood sugars and blood pressures. There are safe glycemic targets for elective surgeries, like you have HbA1c of 7% or less, which is required for elective surgeries. But if we consider diabetic tractional retinal detachments, which are involving or threatening the macula, then that HbA1c target may not apply over here. So a recent good enough control might be good enough. So in most of the studies, there is no mention about the recent control, like how long you need to have a good control. But majority of us would consider even a couple of weeks, maybe 2 to 3 weeks of good control before taking up these patients for surgery. Now, blood pressures and renal functions should be very, very well controlled before taking these patients for surgery, because there will be profuse bleeding when you are encountering such vascular tissue or fibrovascular proliferations. If the patient is again on anticoagulants, then you need to modify them or stop them before surgery in consultation with the cardiologist. And if there are any infections, whether be it periocular infection or any systemic infection, such as a diabetic foot with an active infection, then you should avoid surgery in those patients. Now, imaging is very important when you take these patients for surgery. Like we see in this patient, we see there is a tractional detachment along the supradermal arcade, but we cannot be sure whether that extension of the tractional detachment is happening into the macular area. So you need the macular OCT, and even though there is no macular extension of the tractional retinal detachment, what we can see on the OCT is that the tractional schisis or splitting up of the retina is going right till the foveal center. So now this is going to affect the vision of the patient, and you cannot observe these patients, and you have to take up these patients for surgery. And in the bottom image, you can see there is a significant tractional component on the disc as well. And so a vitreopapillary traction is also significant in this patient. Coming to ultrasonography, so you resort to ultrasonography when you cannot evaluate the fundus because of dense hemorrhage or media opacity. So in this patient, you see an extensive fibrovascular proliferation, but you cannot make out whether there is any tractional retinal detachment underlying this proliferation. So when you do an ultrasonography, then you see that there is a tabletop tractional retinal detachment, and you have to be mentally prepared to deal with it. Now, the objectives of a surgery remain to remove the traction from the macula, that is the primary objective, remove the traction from the arcades, that is the secondary, and then remove the traction from the disc. So this is the main objective, that you remove any traction from the posterior pole. Peripheral traction need not be completely removed. That is not the main objective of the surgery. Now, you have to avoid iatrogenic breaks at all cost, because you don't want the rhegmatogenous retinal detachment to develop in these cases. And last, you have to achieve hemostasis during the surgery and prevent any rebleeds to happen in the early post-operative as well as late post-operative period. Now, pre-operative anti-VEGF and laser play a very crucial role. And if you see this patient, you can not think of entering this eye without giving any pre-operative anti-VEGF, because it's a very vascular tissue and it is likely to going to bleed, and you're not going to find any cleavage planes easily. So if we give pre-operative anti-VEGF maybe 3 to 5 days before surgery, then it reduces the vascularization, it facilitates the dissection, and it reduces the risk of intraoperative breaks as well. And similar is the role of preoperative PRP. So if it is possible, you should do PRP away from the tractional retinal detachment, because it will act in lines of anti-VEGF injection, although not very promptly, because the effect will come in a couple of weeks. But still, if you have a couple of weeks before surgery, it's always better that you do laser away from the tractional retinal detachment. In addition, it also helps in peripheral hyaloid separation that eases your surgery. So if you see this patient, when we took this patient up after doing laser in the peripheral area and giving an anti-VEGF injection a couple of days before surgery, you can see how the vascularity of the tissue has reduced during surgery, and this tissue can easily be dissected and segmented without risk of intraoperative bleeding and complications. MIVS remains the key to safe surgery in diabetic vitrectomies, be it 25 gauge or 27 gauge. 23 gauge instruments are more rigid. They allow for faster vitrectomy, but 25 and 27 gauge, they have ports which go very close to the tip, and bevel tips, if they are there, then that allows dissection and segmentation and as well as delamination very close to the retinal surface. Valve cannulas, the importance cannot be highlighted enough, because intraocular pressure control is very important in these surgeries. Otherwise, with a sudden collapse, you can have profuse bleeding occurring from the fibrovascular proliferations. Now, the aim of the surgery is to remove the membranes from the posterior pole as much as possible safely. And there are different approaches that you can use, the most common being the inside out or the outside in approach to the membranes. In the inside out, you target in the peripapillary area first, and then you go out as you dissect these membranes. And in the outside in approach, you start from the periphery and then approach the center later on. And you use either segmentation or delamination. Segmentation is preferably done for denser membranes, and delamination, thin friable membranes could easily be delaminated. And all these maneuvers can either be done unimanually or bimanually using a chandelier illumination. Now, coming to a few surgeries that will highlight these tips. So it's a 25 gauge vitrectomy which is done here. And you can see that we have started with the peripheral hyaloid, which is already separated. We are removing it, separating it so that the tractional retinal detachment is separated from the vitreous base area. So we are going all around, and you have to be careful that the underlying retina, you have to be wary of the underlying retina, that you don't create any breaks in the underlying retina if it is detached. Now we are approaching the fractional retinal detachment. We are going from outside in, and carefully you lift the membranes and see the underlying retina before cutting. So this is segmentation that is happening between the different vascular epicenters. It's always better to do it in a high magnification. And again, we are resorting from now inside out. We are going from the disc to out. Again, we are segmenting around the vascular epicenters, and the membranes could be very tightly adherent. So it's always better that you insinuate your cutter tip between the membrane and the retina, find a plane, and then segment it. So once you are done with your segmentation, you have to ensure hemostasis there and there itself. So if there are any bleeders, try to diathermize them there itself, because otherwise the coagulum may form and then it might be difficult to remove it later. It's always important that you identify the posterior most haloid in these patients, because there often could be vitreochassis present. And like you can see over here, there's a flimsy posterior haloid membrane that is still left. And if you remove it, then that will ensure removal of the complete traction in your cases. So here we can see that we have removed the posterior haloid membrane also. Once it is done, then you can approach the proliferation at the disc. You need not peel it off from the disc, because then there may be bleeders which you may not be able to diathermize. Always better to leave some stump. Now then you move to the periphery, and if there are thin friable membranes that could be easily delaminated, you can delaminate, as we can see here. But with the cutter itself, now we are delaminating it rather than segmenting it further. When you complete the vitrectomy, a peripheral shave vitrectomy is to be done, because that acts as a source of VEGF, and that can lead to anterior haloidal proliferations later on. So it is very important that you remove the blood in the vitreous, in the far periphery, in the vitreous base area. Now, once you are done with the removal of the vitreous, then you proceed with your fluid exchange. Ensure hemostasis again at this step, and then consider laser for the areas which are away from the tractional retinal detachment. Once your laser is complete, then you need to provide in tamponade. That could either be gas in simple cases, or it could be silicone oil in complex cases. Now, another case wherein you can see that there is a complex tractional retinal detachment, and we are again segmenting it. Now, with the dominant hand, I am doing most of my maneuver, but here I'm finding it very difficult to segment it further. So you can always switch your hand. You can go to the non-dominant hand, and if you are a little ambidextrous, then your surgery becomes very easier. So here, after changing your hand, you can segment it better. You can have a better approach to the dissection. Now I am resorted back again. I'm shifted back to the right hand. That can help you dissect these membranes easily without causing any iatrogenic breaks. Sometimes you are not able to find any cleavage plane, so it's better that you choose the papillomacular bundle area and try to lift the haloid in that area with using a forceps, and then you get a cleavage plane, because this area is it is not firmly adherent with the underlying retina, and you can lift the haloid in this area very easily. The conventionally, what we cut is how do we approach these membranes is that we face the cutter tip toward the edge of the membrane, but then you can also have a flip or rollback cutting in which you place the cutter over the membrane, and then the membrane curls into the cutter. So that way you are very away, you are far away from the retina, and your iatrogenic breaks happen very less often. Coming to the bimanual surgeries, yes, bimanual surgeries make your life easier, and so with the chandelier in place, with your non-dominant hand, you can lift up the membranes and then sever the connections between this membrane and the underlying retina, and your surgery becomes quite easier with bimanual approach. Coming to the last, it's a case of rhegmatogenous retinal detachment occurring on top of tractional detachment. That it is a secondary rhegmatogenous retinal detachment, and you see a fibrous proliferation which is tightly adherent to the underlying retina. You're trying to manipulate now again it's a bimanual dissection, but you're using a blunt instrument such as your endoilluminator itself to remove the fibrovascular proliferation from underlying retina, diathermize the base, and then segment it. Internal limiting membrane is not often required in majority of the diabetic traction retinal detachments, but it can be considered if there is a rhegmatogenous retinal detachment and there is a obvious epiretinal membrane which is present at the starting of the surgery. So how do you achieve hemostasis in diabetic traction retinal detachments? Other than raising intraocular pressure and using endodiathermy, you can also use PFCL. PFCL acts not only as a tamponade, but it exerts pressure on the bleeders and it reduces the bleeding temporarily. You can also switch to fluid air exchange. A coagulum will form under the air quickly, and then you can resort to that managing that coagulum later on. And last, you can always wait for a couple of minutes. Most of the bleeders will stop bleeding on their own, and then you can tackle them later. So the key points that you should need to remember during dealing with any diabetic with the traction retinal detachment, it is important that you have a very good systemic control, not only before surgery but after surgery as well. Preoperative anti-VEGF injection and not only anti-VEGF injection, laser also helps in reducing the vascularity during vascularity of the tissues and helps in easy surgery. And proper identification of the posterior-most hyaloid is important. If you leave this hyaloid behind, then and you have iatrogenic breaks, then redetachments are very likely to happen. Segmentation and delamination remain the core principles for clearing the traction, and it can be done unimanually or manually, as I've shown. And the prime objective, other than removing the traction, is to avoid any break, so that you can leave these eyes under air or even gas. And silicone oils are usually resorted to if there are breaks, or you cannot remove the traction completely, or depending on the patient and surgeon preference, it can also be chosen. Thank you.
Thank you so much, Dr. Devesh. Excellent surgical videos.
Very
and,
nice.
Very, very nice. I would like to invite Dr. Mitra to say a few words to sum up our sessions today. And
Why?
then
Dr. Piyush Bansal? Dr. Piyush Bansal is not here.
Ma'am, two of our guest lecturers, I think, are not here today.
Okay.
So we will be concluding the session for this midterm JHOS. And Dr. Mitra, can you please say a few words to conclude? And then I would like to invite Dr. Malay to give the vote of
And
thanks.
Dr. Vibhuti Bhushan, are you here? Dr. Vibhuti Bhushan, are you here?
Yes, I'm very much here.
So first,
Dr. Vibhuti is here.
Dr. Vibhuti is here. So first, you say something because you are always off the line. So right now you are online. So first you say, and Dr. Mitra is always online. So he will say after you.
I was also always on the line. There was a period when we had a little bit of glitch.
In the meantime, we are calculating the result. The two judges did not judge. So we have two judges and we are sending the mark sheet to the coordinator room.
It was really a fantastic Sunday that we had, full of academics. The innovators session was out of the world actually, and we are eagerly waiting for some of the innovations to come into the market so that we can use them and start using them. And the master's talk was also very, very enlightening, and there was a lot to learn for us who have been in the practice for last 20 years, almost 20 years, but still every day you learn, and you learn from the masters. There's so many good points to pick up and very practical tips that we learned. And overall, it was a wonderful experience listening to, and especially the case presentations by the PGs were really excellent. And that shows that how well they are being guided at their institutions by their seniors, by the faculty members. So I must thank Dr. Bharti for designing a wonderful scientific extravaganza that we had today. And that's all from my side. Excellent experience, excellent session.
So over to
Thanks.
Mitra.
Yeah. Thanks everyone. Now as we come to the end of today's part of JHOS midterm conference, I must first of all congratulate our PGs. They are exemplary. Their
Yes.
presentations are excellent. And as I feel proud to see that PGs are improving day by day in each coming conferences. And thanks to all their mentors, actually. Thanks all to their mentors.
Yes, is correct.
The first session, the hackathon, which was started by Dr. Bharti Kashyap herself by our
Then you were
CSC.
secretary.
Yeah, I was secretary, and kept us glued to the computer. And what a session to start with the conference today. What a session. The out of the box thinking by the innovators kept me thinking about their thinking. I was thinking about their thinking. Be it Moxie Glow, be it Blink Alarm, be it Dots, be it the laser axis. Every presentations were awesome.
Even the first year
We
resident
eagerly,
has in yes.
yeah. We eagerly wait for the second part of the JHOS midterm conference. Thanks everyone, and proud to be associated with JHOS. Thank you. Thanks everyone.
And over to our treasurer, our secretary, Dr. Sujay Samanta is in USA, and he tried to join, but because of some network issue, he could not join. So he has sent a message to the group, and now vote of thanks will be given by our treasurer. But should we wait for the result or should we do vote of thanks? Because what do you say, Dr. Malay?
I think we should wait for the result.
There are two evaluators, they did it. So I have sent the result. Dr. Rahul, you are there? Dr. Pritish?
Yes, madam, I'm here.
Okay, I'm sending the result to you. In the meantime,
Meanwhile, any other announcement you want to make? The CSC, madam.
So actually, we were doing the second part on 21st of September, but there is ISOC, they said, and we have to again reschedule it. And as you know that we started the international hero session in the midterm part 2, and this time we have invited Dr. Kamran Riaz from US. There's a half an hour session by Kamran Riaz, and he is also going to give very nice innovative talks. And his talks, he's a cataract refractive surgeon, but his talks are for emulating all the general ophthalmologists also, like 5-fluorouracil neovascularization, cornea neovascularization, that a general ophthalmologist also can go for. And other thing is that I am also really surprised to see the standard of PGs. It is actually it is actually improved. Actually, our gadgets are also improved. They are showing nice pictures, nice videos. The base hospital where they are working, the hospitals have also improved technologically. Dr. Kashyap, I request you to ask the managers to give the print of the mark sheet kindly, because I am here.
I like the confidence of the PGs, their body language, their body language is
body language.
Yeah.
It was
That is excellent.
they were just like consultants.
Yeah.
Just keep continuing. I am going to the coordinators hall.
Shall I announce the result, ma'am?
Yes.
Yeah. Result has come.
Yes.
Surprisingly, we have 2 second winners.
Yeah?
2 second winners and 2
जोर
third
से.
winners. We have 1 winner, 2 second winner, and 2 third winners. Joint winners.
Joint winners.
Right.
Joint winners, yeah.
The third prize goes to, one is Neha Chaudhary with 85 marks. And another is Dr. Payal Sarkar, third prize, joint winner.
Okay.
Congratulations.
And
तुमको अब 3 प्राइज के बदले you'll have to keep 5 prizes.
Now the second joint winner, one of them is Dr. Shubham Singh and another is Dr. Irshad Khan.
Wow, congratulations.
One is Dr. Shubham Singh and another Dr. Irshad Khan.
Okay.
And the final winner of this session is Dr. Anamika Chaudhary.
Wow, congrats.
Congratulations.
Winner is Dr. Anamika Chaudhary. Joint second winner is Irshad and Subham. And third winner is Neha and Payal.
Okay. So, institute this Irshad, Anamika Chaudhary is from Rio Rims. Irshad and Shubham are from Kashyap Memorial Eye Hospital, and the third winners, they are from which institute?
MGM, ma'am.
MGM.
Both
Ma'am,
are
MGM.
Gandhinagar.
Jamshedpur.
अच्छा चलिए
Jamshedpur, ma'am.
अच्छा कोई बात नहीं है. It's just a participation which matters. Result तो आना जाना है. Next year again they will participate.
So they are
And some-
getting some memento and certificates in the annual conference?
Yes, we will. I am going to for a 1 week camp to a very remote area. After I come back, then we will prepare the certificates. And last year, Ajanta Pharma had given mementos to all the participants. So we will request them to give memento, but it will take 1 week. After 1 week, I will start the work because I am going for to Santhal Pargana, Sahibganj, Pakur, and Jamtara tomorrow itself. And my secretary is also going, my entire team is going, which is doing all these conference work. So this
But I think all the PGs should get the certificate of presentations. All the PGs.
of course, everyone will get
Definitely.
trophy
That is-
also. Last year they said that everybody wants a small trophy. Everybody will get a trophy. First, second, third will get little bigger trophy. That's it.
Okay.
Last year we gave
Thank you.
trophy
Thank
to
you.
everyone.
Hello,
Thank you.
TSC, hello. राशि
Yes.
बोल रही है, हम लोग कुछ नहीं मिलेगा, इतना मेहनत कर कुछ नहीं मिलेगा.
अरे राशि स्पॉन्सर करा देना हमको.
राशि कुछ नहीं बोल रही है.
तो इतना अच्छा होममेड फूड खिलाए, बताओ. अब ये देखो कि अब सुनील मेरे को हेल्प किया तो अजंता से हमने कराया.
Very nice, very well done, Dr. Bharti. Dr.
Nice.
Malay to kindly, please, Malay.
Yes, sir.
Vote of thanks हो जाए यार थोड़ा.
Yeah. I think that was a very fantastically arranged and fantastically run conference. Good afternoon. This brings us to the end of today's session. And I would like to thank all the innovators for sharing their fantastic ideations. And we are eagerly awaiting for them to be available in the market. And I would like to thank all the speakers for sharing their knowledge and giving us the tips. Thanks are also due to all the judges for their insightful questions and suggestions. I would like to thank all the chairpersons and session coordinators for running the show in time. And thanks are also due, as Dr. Mitra and everybody has pointed out, to the future of our societies, our PGs, who have fantastically presented the case presentations. And thanks are also due to their mentors. And thanking all the attendees for taking out time to attend the session on a Sunday. And last but not the least, I would like to thank Entod Pharmaceuticals for arranging the Zoom meet. Thank you. Thank you very much.
Thank you. Thank you very much.
Thank you. May I request all the members who are the members of the ROF, Rashi Ophthalmic Forum, we are going to get our society registered. So I'll be sending my person for his signatures. Please keep your one passport size photograph, one copy of and one copy of Aadhaar card and one copy of PAN card. So they'll go and get it, get his signatures, and then they'll get all those photographs and Aadhaar card and PAN card. So all the members are of ROF.
Thank you. Thank you all.
There are some important announcement.
The coordinators are
It seems that the decision was given on the marks of one judge. The other judge's mark is getting added up. So I think there'll be some kind of a correction. चलता नहीं ये क्लास announce कर दो
बोल रहे आप करिए
there is a little bit of correction in the result of the free papers.
थर्ड में है शुभम सिंह
Third is Dr. Shubham Singh. Third prize goes to Shubham.
second is Irshad
Second is Dr. Rishad Khan.
and first is as advised Anamika Chaudhary.
Anamika Chaudhary remains the first. So this is a little correction. We are sorry on our part. थोड़ा जल्दीबाजी के चक्कर में थोड़ा सा we are sorry.
का दिया गया था
तो हाँ ठीक
Dr. Bhati, do we conclude? You're muted, ma'am. I can't hear you.
Look. Yeah.
So am I audible now?
Loud and clear, ma'am.
Yes, I am very, very thankful to Entod. They help us a lot in our online activities and especially on Sunday, because I heard that on Sunday you people were giving very tough time to some other state society, but you did not give us tough time. Thank you so much. And we took a lot of your time, late evening when your office was closed, lot of correction. So thank you so much. Thank you.